Donna to join.
Okay.
She is on her way. She'll be 1 second, I imagine.
Okay. Shall we rock and roll then? Okay, good morning everyone, and a warm welcome to the March board meeting of Sussex Community Foundation Trust. We're conducting today's meeting by video conference, and we're also live streaming the meeting so that our governor, staff and members of the public can view the discussion and submit any questions or comments that they might have. After board discussion on each item has been completed, we will pause to see if there's any questions coming in from anyone else viewing the meeting. We're going to start, as we usually do, with Employee of the Month. However, starting in February, we've introduced a new and additional way of recognising the hard work and commitment of SCFT staff with the introduction of Team of the Month, and I'll say more about that a little later. Let's start with Employee of the Month, and the January winner is Helen Mustard. Unfortunately, Helen can't be with us, but Helen is the team lead down at Regis Community Team in Bognor, and Tony Hayes made the nomination, and she said that Helen commenced in post only 3 months ago and inherited the team with a high number of daily deferred visits to our patients. Active member of the Trust-wide Deferrals Working Group, and has herself reviewed the team's caseload along with supporting her clinical staff to ensure patient care is of the best quality. And at the time of writing this, Tony said that in the middle of a pandemic, for the first time in a number of years, Regis Rural Community Team have no deferred visits. And have also identified some resources to support responsive services down in Chichester. Tony says, I'm so impressed with how Helen has quickly identified the contributing issues and has not been afraid to tackle them to deal with this problem. And she wanted to make sure that she was recognised for the work she had done. This work's not just had a direct impact on Helen's own team, but it will get benefit for us across the trust. So our January winner is Helen Mustard. I'm going to move on now to our February winner, who also cannot be with us, unfortunately. And this is one of our senior HR advisors, Roberta Lyons. Now, the nomination came in not from someone in HR, but from a member of our staff, Valerie Perkins. And the nomination started by saying, without Roberta's support over the past year, I would not have been able to cope. I was unlucky enough to contract COVID-19 last March. I thought it was just a virus. I'd be ill for a few days and then get back to work. But I was unlucky and I ended up in intensive care. 10 months later, I still have problems and I'm currently still shielding. Roberta has been a great support throughout. She has helped sort out my wages and she's trying to help me get back to work safely. She has always been there for me, answering my questions and just generally being brilliant. Always calm and reassuring. I feel she deserves some recognition for all her efforts. She goes on to say, Roberta's absolutely amazing. And when I needed support the most, she was there. I don't know what I would have done without her. And that sounds to me like a very, very deserving winner of the February Employee of the Month. Let's put our hands together for our colleagues. Okay, now I said we had this, a new way of recognising our staff, and that is the Team of the Month. And the inaugural award for this was for February. And I'm delighted to welcome Sue Dawson. Welcome, Sue. Thank you for joining us today. And Sue's here on behalf of the county-wide immunisation team, who are the first winners of our Team of the Month. And Deborah Miller made this nomination, and what it said is that over the last few months, the teams have been involved in opening up and training the new COVID vaccination centres at Brighton, Eastbourne and Etchingham. and have also assisted at Worthing and Chichester hospitals. The team have provided expertise to assist with training staff in the art of mass vaccinations using the experience that they've gained from working in secondary schools delivering vaccinations on a regular basis. The team have been involved in training non-clinical staff to administer and draw up vaccines and vaccinations. All staff within the team have been involved in training staff, from administrators to qualified nurses. All team members have stepped up and taken on extra responsibilities. Staff have worked long shifts and travelled long distances to attend the sessions. All staff have worked with a smile on their face. The people who have been trained have all enjoyed the experience and been complimentary about the team. Deborah says, I am so proud of the team for stepping up when needed and feel that in these dark times, this would be a lovely surprise for the team if they were to win an award and get recognition for what they have contributed to the pandemic and the trust. So let's put our hands together. Sue, a very well-deserved award. Thank you very much for all your hard work.
Thank you.
Sue, we'd be delighted if you wanted to stay online, but you may have more important things to go and do. So thank you for coming along. Did you want to say a few words?
No, thank you. And I underline everything that's said. We are all still helping in the centres in different ways. So it's been great, actually. It's been really good for the team. Lots of experience that they've got from helping with the teams in the COVID centre. So it's been great for everybody. Thank you.
Well, please pass on all our thanks and congratulations, won't you, when you get back?
Thank you very much.
Thank you. Take good care now. Right, that takes us on to apology for absence and the first item on our agenda. Zoe, I understand Caroline Haynes is not with us today. Are there any other apologies?
No, Peter.
Okay, thank you very much. Any declarations of interest not otherwise noted in the schedule? No. Which takes us on to the minutes of the last meeting. Comments on the minutes accuracy. Right, I will take silence as assent. If you're on mute and you want to make a point, well, it's too late really, isn't it? Thank you for that. We will therefore accept the minutes as a correct record and move on to the action log. Now, the first item is about revisiting the NHS long-term plan, but clearly we're not in a position to do that yet as we wait further guidance from the centre. Hopefully come out of the current period soon. So I think we need to defer that one for a few months yet until we get further guidance. The other three items have all been complete, Zoe, so can we take those off the list? Thank you very much. That takes us on to item 4, and we have an update on operational planning. And Mike, you're going to tell us what the latest position is, I understand.
Thank you, Peter. So I've got an update today on operational planning for the board, and I can tell you how things are developing and panning out for 21-22. We've also in here got the capital plan, and so I'd be asking the board to approve the submission of the capital plan as laid out into the ICS capital process, and I'll say a little bit more about how the ICS governance kind of plays in to the final capital plan. So the paper lays out an update on operational planning. The board will remember that we have this year been in a different set of financial kind of rules and a different financial regime due to the pandemic. We have been told that something very similar to the financial regime we're currently in will be rolling forward into Q1 and almost definitely now into Q2 as well. So we expect for the first half of the year to not go back to kind of normal financial regime and normal contractual rules. So that means we don't have all of the detail on that. So there may be some adjustments and some changes made to kind of the broad kind of block payments that we get and the top-up payments But there have been recent announcements around continuation of some important factors into the first part of next year, such as hospital discharge programme, which is very important to us and supporting some of our developments, such as the Home First pathways. So more and more information coming out on this, but I thought unusually for this time of the year that we would be, normally we would be signing off a plan for the forward year. And so even though I don't have all the detail, I think it's important for the board to note where we are in that planning process and where the national team are. On the report, we set out some of the risks and opportunities created by the fact that we're going to continue, at least for the first half of the year, it seems, with the ongoing financial regime, sort of emergency financial regime. And the table on page 14 lays out some of those. So, and essentially to summarise, delays in a contract round means there'll be delays in potentially some additional recurrent funding that we were seeking to balance out maybe some underinvestment in certain areas of the contract. It also means we get delays in having recurrent funding for some important developments, such as the expansion of Home First pathways within our urgent community response teams. Although non-recurrent funding may still exist, as I've just said, the hospital discharge programme, for instance, giving us some non-recurrent means of covering those costs. And it also means there's a delay in bringing forward, as we just mentioned in the actions, some of the long-term plan priorities that we were discussing before the pandemic. There are opportunities as well. At the moment, the regime doesn't include an efficiency ask because of obviously the strain on services in dealing with the pandemic. So therefore, there isn't an efficiency programme to enact in the first half of the year. You get some kind of certainty from it, and we have a reduction in kind of the normal contractual negotiations and resolutions that the teams have to support, and that frees up time for us to focus on coming to these last stages of dealing with the pandemic, moving into a sort of reset and recovery stage, and also continuing to manage our element of the vaccination programme. And all of those things are taking up a huge amount of time and resource. So the extra time freed up will be welcome. I'll pause there before I go on to the capital plan, Peter, to see if there's any questions on operational planning.
Okay, thank you for that, Mike. Maggie, you have a question?
Yes, just some assurance. So where we've got services that we're running without long-term funding, how are we managing the workforce risk?
So in terms of, and I think we discussed this at a board back last year. So in some of those expansions, such as the Home First expansions, we know the expansion of urgent community response is an aspiration of the long-term plan, and therefore we're expecting longer-term funding to come forward. And so we agreed with our ICS partners that some of the expansion of that, for instance, area of the workforce would be substantive posts as well as temporary. There was no way we would actually been able to have expanded to the amount we have without some substantive recruitment. So we've gone forward with a managed risk, knowing that the current cost of that will be covered, knowing that the long-term plan funding is coming forward to give us some recurrent, and in the absence of all of that, knowing that we are recruiting to registered clinical staff, and actually we have plenty of kind of vacancies across the registered clinical workforce, as well as a final mitigation if long-term plan funding didn't materialise, although there is no indication that there is not going to be a return to that long-term plan increase. And in fact, recent indications that that kind of community and primary care increase in services is going to be a ring-fenced element of the financial architecture when we go into the second half of the year. So it's a small risk, but we decided that that risk was worth running because of all of the information we had in front of us.
Okay, so the staff are clear that they're employed substantively. I don't want to be losing very valuable staff. That's
absolutely.
Yeah,
absolutely.
Thank you.
Okay, thanks for that, Mike. Shall we move on to the capital programme?
Yes. So the difference in the financial architecture between capital and the normal operating plan is that we still, and this probably relates back really to the way capital budgets are set at the Department of Health and Social Care level. The CDEL, the capital expenditure limit, is set for that department, and therefore the NHS capital limits kind of roll down from that, and therefore we have to set a capital plan within more or less the normal time frame. So we therefore have a capital plan in front of us for recommended to the board for approval. It's been through our normal diligent processes of prioritising across different schemes to come to this level. It's a larger capital plan than we've ever seen, actually. So we are both using our ability to utilise sort of cash generated in previous years, not so much in this year, but in previous years, around sort of surpluses we generated to augment a capital programme, plus looking forward to the second part of the digital aspirant funding that we've been successful in this year. That's not guaranteed, but again, strong indications that we would be successful in that application. So that leads to a 12.1 million capital plan, and page 18 sets out some of the areas that 12.1 million plan falls across. And I'll stop there for questions, but the board is recommended to approve this. We will put this forward to the ICS because the CDEL, the capital budget, is set at a system level, not set at an organisational level. So all organisations need to put in their plan. We need to work out how that fits within a system budget. If it does not, there will be needing to be some form of capital prioritisation across Sussex before we get to a final plan.
Okay, thank you for that clarification, Mike. And it seems we've done particularly well on digital funding, which is good to hear. Stephen, the Resources Committee considered this on Tuesday. Anything you want to add to start with?
Yes, we did discuss it at the Resources Committee on Tuesday. You're quite right, Peter. And I think we fundamentally welcomed the shape of the investment that's proposed, because there's still a strong element around digital, and that's actually going to be the third year in a row that we're putting substantial money from the capital budget into digital, and that's exactly right for resilience, for new equipment, and actually new ways of working. So that's really, really important. So very supportive of that. There's a continued investment in estates, which is very necessary, because we've still got sort of significant risks around our estate, and obviously we'll be building back in the BGH redevelopment into the proposal as well. So I think it's very balanced. And I think actually, having discussed it, I think the Resources Committee would recommend that the board approve it. It then obviously, as Mike says, still has to go to the ICS. So I would endorse it, would be my summary.
Thank you very much, Stephen. Elizabeth?
Yeah, it looks very balanced to me, and equally very happy to see the digital focus. What I've seen in the past, it's quite useful as a sense check on capital plans to see how they map towards the big pillars of a strategy of an organisation. And it would seem on the whole it does, because you'd imagine that patient experience is a big one for us, and digital transformation will help that. But do we see any areas of our strategy that are still not really being supported by the capital plans?
Through the process that came forward, there was no single area of our strategy where I would say that schemes were being put forward and we had to push them back. That's slightly different to saying, are there areas of the strategy that could do with more sort of, for want of a better word, plans or ideas to push them forward? But there were no known kind of areas of the strategy that were disadvantaged severely from this.
Okay, Maggie, you want to come in?
Just a point of detail. Have we included in anywhere on this, and it's probably too much detail to have here, but just assurance really, the issues that we need to address around staff wellbeing? So staff restrooms, breakout areas staff can go to, relax a bit before they go back on duty.
We have a specific pot set aside for staff wellbeing schemes. Whether they will fix all of our issues across the trust next year, I don't expect they will, but they will go some considerable way to be able to enhance or improve or create some of those areas that you're talking about.
Thank you.
Okay, thanks for that, Maggie. On that note, are we happy to approve the Trust's proposed capital plan for further submission to the ICS? Yes? Excellent, thanks very much. That takes us on to...
Peter, Zoe's hands up.
Oh, I didn't see Zoe. Zoe, you're on mute, Zoe.
Apologies, sorry. I have a question that's come in via the live stream and I wasn't sure if you wanted to take it now, Peter.
Let's take it now.
Great. Okay, it's a question from Martin Ensom. And Martin asks, how will the ICS decide on capital allocation? Are SCFT involved in that decision making?
So yes, the ICS, we are part of the ICS. So it is the first part. It's not kind of another shadowy body elsewhere. All of our sort of senior team are involved in the ICS in some way. This will be looked at via first the ICS finance group, which involves myself and Ed Rothery, our Director of Finance and Performance, and they will use, if the sum of all the schemes doesn't fit within our envelope, and it may well fit, if it doesn't, they will use an agreed prioritisation methodology to objectively rank and look at schemes and put them forward. And then that approval of that scheme would then have to happen through the ICS executive that would include Siobhan as well. So we have kind of influence and take part in that process all the way through.
Thanks for that, Mike, and it'll be interesting to see how those discussions unfold. And thank you for that, Zoe. Sorry I missed your hand there. Let's move on to the integrated performance report. Mike, you're the report owner, although I know this is a collective effort from several people. Is there anything you want to say by means of introduction before we start going through it?
So we've got the format of the report with highlights. Not all areas have highlights this month, but we'd previously agreed highlights would be written where there was material to be highlighted to the board rather than always be a standard in each section of the report. I think I won't go into individual bits of detail, but you can see, and exec owners will talk through some of our adverse variation relating to some of the impacts of the pandemic, and therefore some of those adverse variations may take some time to recover as part of our reset recovery, the other side of the pandemic. That's my kind of general point I think I'd make out of it, but there is some strong performance in other areas to balance that out. But I will let individual execs talk us through their individual exceptions.
Okay, thanks for that, Mike. And before we start with quality, Siobhan, I wonder if you could just give us a brief assessment of where we are in terms of the impact of COVID and the vaccination programme.
Thank you, Peter. So I'm pleased to say that the impact of managing COVID positive patients has dramatically reduced, which is in line with both the community case rate numbers in Sussex and across the country, and the knock-on hospitalisation rates, which for us in Sussex peaked in January. So through February and into March, we've seen a steady decline, and as of yesterday, we were managing just 6 COVID positive patients in our inpatient beds, which is the lowest number that we've reported since around about October last year. So really positive in terms of the direct impact of COVID positive patients. In terms of the vaccination programme, board colleagues will be aware that we have a fairly significant role in running the 4 vaccination centres across Sussex, which are Eastbourne, Crawley, Brighton and Chichester. And we scaled up last week for the first time to maximum capacity, which was based on the increased availability of vaccine and our monumental efforts in onboarding 1,400 additional staff to run the vaccination programme. Last week, we were notified that there was a significant shift in availability of vaccine for the month of April, and that means that the national leadership team took a decision to temporarily suspend the booking of first dose appointments at all vaccination centres across the country. So that's the at-scale vaccination centres that are accessed through the national booking system. So we're managing a tricky message at the moment because we're running at our busiest last week and this week, but from the beginning of April that will slow down dramatically, and we will not be booking first dose appointments into those centres as per the national rules of engagement for the month of April. We will, however, be seeing people in the centres for their second doses that are already booked, and we've had confirmation that the vaccine supply for second doses will be allocated as per booked appointments. So we're in the process of talking to system partners, to directors of public health, to GPs around how our staff could be proactively used in different models for the first 2 weeks of April in particular, to ensure that we continue the focus on the JCVI cohorts 1 to 9, because there's still around about 160,000 people in Sussex as of yesterday who are in JCVI cohorts 1 to 9 who don't yet have a vaccine. So we know that there is some more concerted work to do with harder to reach communities and harder to reach individuals. So we'll place our focus in early April on that effort. But it is, the news is breaking in the local media about the impact, particularly in Kent and Sussex, where there are, in Kent there's 5 and in Sussex there's 4 large-scale vaccination centres, which will have a very different level of activity running through them in April. So it's an emerging kind of story. Mike and I are working with system partners around what options we have to create pop-up clinics, outreach clinics, to think differently about the roving model that we already have. But there is a difficult message for our staff, the vast majority of whom are bank staff, in that there will not be the availability of bank shifts into April that there has been for March. So it's the main constraint on this programme all the way through has been vaccine supply. But we had an early indication that it was secured for the forthcoming 2 months, and then at the middle of last week we got notified that April is a problem in terms of vaccine supply for us nationally. So it was just really to inform board colleagues of that, because I know in the IPR the vaccination programme is mentioned through the lens of the quality spotlight and the governance. So it was just to set the context, which has changed quite dramatically over the course of the last week.
Thank you for that, Siobhan. And unless there's any questions, that's a nice segue into the quality report. And Donna.
Thank you, Peter, and good morning, everybody. So the quality dashboard, we have 2 exceptions on this month's report. One is around compliance with a NICE guidance, and the other is a new instance of C. difficile. The exception reports are there. I think they're fairly self-explanatory, but I'm happy to take questions on those. The quality spotlight, as Siobhan has referred to, I've just included some information that went to the Quality Improvement Committee back in February, just to provide assurance around the clinical governance processes of the vaccination programme, and that's just there for your information. I've also included the outbreak information, again, there as a position in time. What I can do though this morning is just update you that as of today, we actually don't have any outbreaks which are less than 14 days and where we have any patients involved in the outbreak left on the ward. So we have 3 outbreaks which are within that 14 to 28 day period where they're sort of on a watch list really, so no patients left on the ward, but still the potential for some exposed patients to be included in that outbreak. But they are just being watched at the moment. So that's really positive news, and again reflects the position that Siobhan spoke about the significant reduction in community transmission.
Thank you for that, Donna.
questions. Sorry.
Yeah, I think David's first, followed by Janice.
Thanks, Peter. Morning, Donna.
Morning, David.
Just two questions, if I may. Firstly, on the, I'm just trying to find my page. On the NICE guidelines point, I noticed that on that report, which is very self-explanatory, there's nothing about timescale. Is that deliberate, or have the gremlins got in?
It's probably deliberate, to be honest, David. I think the issue with the waiting lists and children with suspected autism has been, I think, on the risk register for a very long period of time. Certainly predates me. Kate's nodding here. I think possibly 18 months to 2 years. So whilst we have, and COVID has obviously impacted our ability to manage that. So whilst we have started some waiting list initiative work and we've secured some additional resource to be able to manage that, I haven't been advised of a date, and I'm not sure. I'm looking at Kate just to see if she has, but she's shaking her head. So I don't think we have that clarity yet.
I see. I guess I understand where you're coming from. It just looks very odd that we've got no idea, to put it crudely, when we're going to be able to address that. But I understand some of the difficulties you have. My other question was slightly different, and it was around looking at the Spotlight report and the COVID outbreak that you had on the Brighton and Hove ICU, which I guess slightly surprised me because this was a new sort of ICU that we've just established, and I wondered whether there's any particular issues coming out of the work that you've done in trying to understand the causes for that outbreak that may help in the future. I'm just surprised that it happened on what was in effect a new facility.
Yes, and I think we all kind of shared your disappointment, really. It's also a facility where we have only single rooms. So actually that makes a difference from the point of view of managing transmission. I'd need to check how many patients were involved in this. I think there were very small numbers. I think we're just talking about maybe 2 patients and 2 members of staff, but I can confirm and let you know, David. We have relied on, when we opened the Brighton and Hove Intermediate Care Unit, we have relied quite heavily on temporary staff to come in to support us to be able to open that. And I'm sure you'll remember we opened it in an incredibly quick period of time. So we needed to bring in people on a temporary basis whilst we went through kind of more formal recruitment processes for substantive staff. And I think our learning generally around outbreak management has been around the, I guess, the inconsistency of the approach of some temporary staff. It's quite challenging to work with a group of staff who have very different access to training, to practicing donning and doffing of PPE, of understanding some of the IPC principles as well. So I think that's probably a significant factor within that.
Okay, thank you for that. That's helpful.
Okay, Janice, you have a question.
Yeah, I raised this at Quality Committee actually, but for the benefit of colleagues, there's an item on the chart that isn't highlighted as an exception, which is compliance with hand hygiene. But I think, Donna, you explained that was because we didn't have a time series, and so it hadn't been picked up under the criteria we use, but it does look quite low compared to our target. So I wondered if there was anything you could share with the board about hand hygiene for assurance purposes.
Thank you, Janice. And you're quite right. When I spoke to performance, it was about how they collect data over a period of time for SPC purposes to be able to then identify when something is outside of upper and lower controlled limits, which is why it's not showing as an exception. But I have gone back and had a look at that, and I appreciate the concerns that you've raised, Janice. Obviously, hand hygiene is it's really our first port of defence around transmission of any infection, not just COVID as well. So some of the issues are around the numbers of services who have been completing those audits. So mainly last year, we paused the audits as part of our broader work to pause audit because we were focusing on our priority services. So we have a limited, and services are restarting doing those audits now, but we have a limited number of audits coming in still. So we haven't reinstated them to the point where the expectation is for 100% of services to complete those audits yet. So obviously when you have limited numbers, then your percentages can look slightly different. What we have looked at is some of the learning that's come out of that. A lot of the learning is again around sorry, and I don't mean this to sound as though I'm blaming staff who are not our staff. I just think it's an important risk factor for the board to be aware of, is that staff who are temporary staff do have probably less access to training around IPC, and have very different experiences depending on other places they've worked in around what IPC standards and precautions need to be. Some of the things that the audit's picking up is around the bare below the elbows principle. We are still finding staff who come in who are wearing jewellery, for instance, and staff who are wearing lanyards, which you wouldn't do in a clinical area. What we have done though is we have reinstated our link practitioner forums and our link practitioner training. So our IPC link practitioners, we have one in every team, and they are the people that are there who can do that sort of day-to-day challenge of their